Second. Okay, please start.
Hello, good evening. I'm Dr. Suganti, one of the doctors in the ward. I am here to discuss with you about a medical problem and examine you. Is that okay?
Yes, doctor.
Okay. Can I confirm that I am talking to Mr. Smith, 37 years old?
Yes, doctor. Correct.
Mr. Smith, can you tell me in your own words what brought you to the hospital today?
So, actually, doctor, I am a little bit worried regarding my weight loss.
Oh, okay. How much weight have you lost and over how long?
Actually, doctor, I have lost over 8 kg weight over last 5 months.
Okay, that's a lot. Okay, was it intentional or no, unintentional?
No, doctor, it's non-intentional, doctor, and this is the first time in my life, doctor.
Oh, okay. Sorry to hear that. We'll see how we can help you with that. And how is your appetite?
My appetite is normal, doctor.
It is normal. Okay. Any change in your diet or exercise pattern recently or
No, doctor.
no? Okay. And have you noted any lumps or bumps in your body?
No.
Okay. And yeah, any raised body temperature, have you noticed?
Not now, doctor.
Okay. And do you have any other symptoms like any weakness, tiredness?
No, I feel generally tired, doctor.
Okay, how long is that?
Mostly last 2 months, doctor.
Okay. Like, do you feel tired in the mornings or in the evenings or
No, generalized, doctor.
generalized? Okay. And do you feel weak in any part of your body or is it a generalized weakness?
No weakness, no weakness in any part of the body.
Body, okay. And do you have any shortness of breath?
No.
Okay. Any racing and pacing of your heart?
Yes, doctor. I feel that sometimes I feel that my heart is beating and I feel the racing or pacing of my heart. Sometimes I feel with efforts and sometimes for last 2 months I feel at rest also.
Okay. At rest also you have this racing. And
Yes,
can you tap it out for me? Is it regular or irregular?
it's regular, doctor.
Regular. And have you noticed this, like when you're doing some activities or increasing while doing activities and decreasing at rest like that? Or,
No, it's sometimes at rest without any activity, and sometimes I feel with efforts.
okay. Any chest pain along with it?
No chest pain.
Any sweating, chest pain?
No,
Okay. And do you have any dizziness, any
no,
blackouts or loss of
no,
consciousness? No. Okay. And any cough?
no cough.
Okay. And how is your bowel habits?
My bowel habits are normal, doctor.
Okay. No loose stools.
No loose stools.
Okay. How is your
Mana aku dah nak
waterworks?
arriba.
Sorry,
How is your waterworks?
whatever is normal.
Normal. Okay. And any weather preferences you have?
Yes, doctor. I like cold weather.
Okay. And have you noticed any hair loss?
No,
Okay. Any difficulty in your vision? Any
no,
double vision?
no,
Any difficulty in closing your eyes?
no.
No. Okay. And have you noticed any swelling in front of your neck or anything?
No, I have not noticed.
Okay. And Do you have any known past medical condition which I should be aware of?
So, doctor, since I had this weight loss, so I went to my GP almost 4 months before. So he said me that I need not to worry regarding my weight loss. But at that time, my BP was little bit on higher side. So he gave me propranolol, 80 mg once a day. And since that, I'm taking the tablet, and I feel good now. My BP is controlled.
Okay, and okay, this racing and pacing of heart, is it daily you are getting, or
No, not always. Sometimes.
okay, is it during some episodes like do you
No, I
feel
have told you that sometimes it comes even at rest also, and
okay?
sometimes it comes with efforts.
Okay, have you been drinking excessive coffee or any recent stress?
No,
No, okay, and any other medication you're taking?
no, apart from this, no,
Only propranolol, okay. And are you allergic to any medications?
no,
Any surgeries in the past?
no,
Any any procedures done recently? Or,
no.
okay. Anyone else in the family with the similar problems or any diseases running in the family which I should be aware of?
No, doctor, not similar problem, but my father had a heart attack 2 years before and he got stent. Right now, he is doing well.
Oh, okay. What was his age when he got a heart attack?
Just 2 years before, he was around 78.
Okay. Then, can I ask you some personal questions? Do you smoke?
I used to smoke, but I quit smoking 2 years before.
Oh, very good to hear that. And do you drink alcohol?
Yes, I do, but within social limit and on occasion only.
Okay. And do you use any party drugs?
No.
Okay. Whom do you live with?
I live with my partner.
Okay. Apart from that, any casual partners?
No.
No. And do you use any share needles or any piercing or anything?
No. No.
No. Okay. And what do you do for a living?
I'm an electrician.
Okay. How has this affected your day-to-day activities and your job?
Right now I feel fear regarding my health and this palpitation. So I am not going to work, doctor.
Okay. We'll see how we can help you with that after this consultation. Do you drive?
Yes.
Okay. And can I examine?
Yes. Yes, please.
I'll start with the hands. Look for any tremors. Um, uh,
Okay. So just give the command to the patient and I
okay.
will give the answer.
Okay. Can you stretch your hands and
Okay. So when the patient is stretching the hand, you can see some tremors.
fine tremors? Okay.
Yes.
And I would like to see, turn the hands over and see for any palmar erythema.
No
Um,
pulmonary edema.
okay. And pulse, I would like to check if it is regular.
Pulse regular and as mentioned
Volume,
outside.
volume.
Volume is good.
Okay, then I would like to check the blood pressure both sitting and standing.
No postural drop.
Okay, then I would like to check the proximal myopathy. Ask the patient to.
Okay, so you check the proximal myopathy and it's negative.
Okay, then look at the hair for any hair loss and eyes for pallor icterus.
Negative.
Okay, in the mouth. And also I would like to see in the eyes if there is any proptosis, exophthalmos.
So yes, you see and you found that the patient has proptosis.
I would like to do lid lag and lid retraction.
So how we will do?
I would ask the patient to follow my finger and I move my hand down.
So lid leg positive.
Okay. Then lid retraction, I would do an inverted U movement and ask the patient to follow.
Okay, it's positive.
Okay. Then I would like to see the mouth.
Okay, what do you want to say?
Any mouth sores, any pigmentation, anything, cyanosis.
Negative.
Okay.
Negative.
Then I would like to examine the thyroid gland. I give a sip of water and ask to hold and bend to the level of neck and see, ask to swallow and see if it is moving. And
Okay, so when you ask the patient to swallow the glass of water and you put your hands, you go behind and you check the glands and it's there. You feel that patient has a diffuse swelling over there.
okay, diffuse swelling. Okay.
Mhm.
Then I would like to palpate and see if it is nodular, anything there, and also see
Not
the
nodular, it's a single
diffuse swelling.
diffuse
Okay.
swelling, yes.
Also check for the lymph nodes and
Okay, lymph nodes are negative.
then I would like to percuss in the front to see if there is any retrosternal extension and also auscultate over the thyroid gland for any bruit.
Okay, negative.
Okay. Then I would like to auscultate the heart for heart sounds and look for any murmur.
Negative. No more.
And okay, then I would like to auscultate the base of the lungs for any crepitations.
No crepitations.
Okay. Then I would like to see the legs for any rash, any pretibial myxedema, anything there. And also look for the ankle jerk.
Okay, negative.
Okay, and also check for pedal edema.
Pedal edema negative.
Okay. Still there is time, sir?
30 seconds you have and then 2 minutes left.
Okay. Then I would like to check abdomen, any also
Abdomen for?
any tenderness, anything.
No. Okay, so you're left with 2 minutes.
Okay, what are your concerns?
Why do I have this weight loss, ma'am? I mean, I have this, my appetite is good. I try to maintain balanced
Yeah,
diet and
yeah,
still I am
after
losing the weight.
Oh, yeah. It is a valid concern. I've examined you and I have discussed with you about a medical problem. I think you have a condition that is affecting the gland in front of your neck, what we call it as the thyroid gland, and it is I think it is overactive and it is causing you all these symptoms of weight loss and racing and pacing of your heart. For that, we have to do some blood tests and also the jelly scan of your neck to of the gland in front of your neck to confirm it. Is it okay for you?
Oh, all right, doctor. So is it
Yeah.
suitable?
We can keep the symptoms under control by we can give you medications to, and you have to be taking them regularly and you have to be on regular follow-up. Do you have any other concerns?
Okay, so doctor, will you admit me?
Um, yeah, since you have this palpitation, this racing and pacing of your heart, we'll keep you under observation, and after the tests, I can get back to you and talk to you after the tests. Is that okay?
Okay, doctor. Okay. All right. So present your positive findings and summarize your case and give me the list of differential diagnosis.
Okay, sir. I um, saw this patient, Mr. Smith, who has come with weight loss and palpitations. And on examination, he has a fine tremor, and there are eye signs like proptosis and with lid lag and um, lid retraction positive, and there on examination of the thyroid gland there was a diffuse swelling of the thyroid, and uh, um, so my diagnosis will be Graves' disease, thyrotoxicosis with Graves' disease.
So what is the diagnosis, ma'am?
Thyrotoxicosis, Graves' disease.
Okay. And what are your differential diagnosis?
Differentials could be any other thyroid diseases like
Other thyroid disease like
multinodular goiter, but I couldn't find any nodules, and it could be any other hard like and like anemia, but there was no pallor.
okay, anemia and other thyroid disease. Anything else you would like to give?
Like there was no history of alcohol, no history of excessive coffee, any anxiety could be other diagnosis. Anemia, anxiety.
Anemia, anxiety. Okay. All right. So how you will evaluate, ma'am?
Yeah. Apart from the basic investigations, I would like to do the thyroid function tests and thyroid receptor antibodies, and ultrasound of the thyroid gland. Then I would like to do chest X-ray, ECG, and echocardiogram. Then next.
Yes, please. Yes, I'm listening, ma'am.
Yeah, yes. Then I would like to do for the complications.
For the complications, any specific test to confirm the diagnosis?
Yes, sir. I think. Then I would like to do ophthalmologist opinion for the thigh.
Okay,
For the
before we
eye.
go to the opinion, any specific test to confirm your diagnosis and any specific test to rule out your differential diagnosis?
Thyroid uptake scan.
Okay, thyroid uptake scan.
Thyroid receptor
Anything else?
antibodies, thyroid receptor antibodies, and
Okay, thyroid receptor antibodies.
thyroid function test first, sir. And then
So first you go with the blood test.
yes, sir.
Okay, what you will see in the blood test, ma'am?
For the thyroid function here, sir.
I mean,
there will
how
be
you will interpret what the result will you get in this case? If you will offer the thyroid test, what result you expect?
T3, T4 will be high and TSH will be low.
Okay.
And thyroid antibodies, thyroid receptor antibodies will be high. And
You tell the thyroid uptake scan. What you will specific find in this case?
diffuse uptake of the thyroid gland.
Then if it is diffuse, then What if it is low uptake?
If it is low, it could be other causes like
All right. So how you will manage, ma'am?
yeah, we can form a education counseling of the patient, multidisciplinary team approach, and we can start on antithyroid medications like carbimazole,
Okay.
and follow up regularly. And if it is not working, then we have to go for thyroid ablation or surgery.
Okay. All right. Okay. Okay. Thank you, ma'am. Thank you so
Thank you,
much.
sir.
It's a very nice efforts and you did it very good.
Thank you, sir.
So before we discuss, what do you think? How it went?
Mm, the differentials, I didn't do properly.
Yes, differential was one of the issue.
Yes, sir.
Correct.
Then
Mhm. Anyone would like to give any comments or any suggestion? Anyone, please? We are just discussing. Anyone can give suggestion. All right. Pheochromocytoma can be DD also. Yes, but uh,
there
not
was no
top three.
episodic
Yes. What
things,
was against the pheochromocytoma here?
no headaches and no episodic
Very good. So there was no
sweating.
headache here. There was no episodic palpitation. Okay. These were against. And usually pheochromocytoma has a weight loss, but not that significant.
Yes.
All right. Anyone else?
Sir,
Okay.
if it is a female, then
If it is a
um,
female, then
we can postpartum thyroiditis
yes, very good.
and this one also, sir, decrevance thyroid.
Decrements thyroid. Okay. But you can keep it, but not according to this history because the history was started almost 5, 6 months and patient has a flu-like illness 3 months before. Okay. That was the history, some of the history you missed. All right. So we will discuss this case. Okay. So you said that you are one of the doctor in the ward. What was your role, ma'am? You are the doctor in emergency.
Emergency. Okay, sir.
Okay. So please pay attention that what role has given to you. Okay. It's very important. If you do this kind of error, they will not spare you.
Oh, okay, sir.
It is written here that your role is you are the doctor in emergency. Okay. So
Yes.
outside the like when you were given 5 minutes, so you got here that patient has a weight loss and palpitation. What DD came to your mind? What do you think?
I thought of thyrotoxicosis, pheochromocytoma, anemia, and because of the malignancy, because of weight loss, some malignancies.
Because of weight loss, some malignancies. Okay. Okay. Malignancies like
Uh, men too, men,
no. So if you thought of malignancy, why you didn't say in your DD?
Yeah, I missed, sir.
Hmm. Okay, so first we will discuss regarding the weight loss.
Yes, sir.
Okay, so if you have been given the condition that the patient has weight loss, you ask about how much or how long, correct? And then you ask about the uh, like what is the second most important question you have to ask is that any change in appetite.
Mm.
Okay, if there is any change in appetite or it is a low appetite, then it could be your chronic disease. Chronic disease, like it could be your Addison disease or sometimes chronic kidney disease. Okay, any chronic infection. What are the chronic infection? TB, HIV, any other chronic infection which might patient have could be brucellosis or any long-term chronic infections. Okay, cancer, any kind of cancer. In this particular case, which malignancy could be the most common?
Yes,
Anyone
sir.
else? Yes, yes, ma'am.
Mm.
Young patient with weight loss, palpitation,
Carcinoid,
carcinoid could be, yes. What else?
Lymphoma.
Lymphoma, okay, yes. But more common than this, GIT malignancy. Okay, in young patient with weight loss, palpitation, you have to rule out GI malignancy or other GI causes. Okay, then connective tissue disease could be your SLE, RA, and CLD. Okay, if it is weight, good appetite, appetite is good, then you can think of hyperthyroidism, your pheochromocytoma, diabetes. Always try to rule out. You can ask the question regarding how is your water work, any polyuria, any polydipsia, okay, and any chronic wound or any poor wound healing, any malabsorption syndromes. Okay,
Mm.
you have to ask celiac disease, okay, sometimes ulcerative colitis, Crohn's disease, and medications. One of the uh, most common cause could be in the patients of young age also. Could be a patient is taking SSRI, could be a patient who is taking thyroxine. Okay, all right. So we have to ask about the drug history. Very important. Sometimes the patient is on diabetes medication, GLP-1 agonist can lead to weight loss, significant weight loss. Okay. So you have to ask very good and detailed history about weight loss. So once you are asking about weight loss, you have to ask about diet, appetite. Okay. And about diet, you have to ask, are you taking balanced diet? Okay. Are you taking proper meal? Do you feel that your diet is as was before? Okay. And then you have to ask about the bowel, like gut symptoms, bowel work, any loose stools, okay, any color change in your stool, any frequency change, any acidity problem. Okay. So you have to ask very good history regarding the GI malignancies or GI causes which can lead to this. What could be other causes in this case? Anyone else? Chronic infections. You have to ask about chronic infection. Chronic infection like TB. Did you have any recent infection or patient had any previous episode, or if he is living with anyone who had a recent infection, the work profile of the patient, okay, any medication which can be immunosuppressive has been started on or recently stopped, okay, and young patient, you have to ask about HIV. Okay, you have to ask about sexual history. Okay, you have to ask about the partner, job, any recent traveling. Okay, and you have to ask about needle sharing history. You have to ask about the blood transfusion history, any tattooing, any high risk behavior. You have to ask everything. Okay, so weight loss history is very important. Okay, once you analyze the weight loss history, so you will get some of the idea, and then you have to go for a palpitation, which has been given in the stem. For the palpitation, just simple. Try to remember with ABCDF. A for your anxiety, anemia, arrhythmia, and alcohol. Almost ma'am has covered everything. Caffeine intake, any medication, anxiety, sleep and mood. Also, we have to ask. Stress. Also, we have to ask. Okay, and any drugs, any endocrine problem could be hypoglycemia, hyperthyroidism, which we have to rule out. Okay, and any association complication like pheochromocytoma, VHL, any balance problem, vision problem, water work changes, and MEN2. Okay, MEN2 will give you some positive family history as well. Okay, swelling in front of the neck and neurofibromatosis. All right. So once you have this idea regarding to approach, so this usually a case is a case of your approach. So examiner will mark you according to your approach. So how is your approach regarding the generalized scheme of the patient, what has given to you, the weight loss and within the 2 minutes you can easily identify by the asking question that your patient has hyperthyroidism. Okay, so once you get the diagnosis, your main task should be to rule out the cause and to look for the complications and also to rule out the other DD. This should be your approach. Okay, so when you ask the history about the presenting complaints. Once you done with the presenting complaint, then you ask about the general history. Always give attention to the general history. General history will be your fever, weight, okay, weather preference, lumps and bumps, joint pain, rash, any pigmentation. Okay, is how is water work, bowel work, stress, and mood, night sweat, okay, and palpitation, which has already given. He had already asked in the initial examination. So history should be very like formatted history, okay, because we have very limited time here. And if you will go here and there, you will waste your time and the time will go on. Once you done with Odipara of the presenting complaints, you go for the general questions and you ask for PDF. Past history, any drug history, any family history, and then social history. Because here to rule out hyperthyroidism is not that difficult, but to form a sensible list of differential diagnoses and rule out every other serious causes of the presentation and treatable causes of the presentation is very important because the examiner wants to see you that are you a safe doctor? Are you able to take your clinical judgment by ruling out the simple as well as the critical condition which can present with this condition. Okay, so you have to rule out malignancy. Malignancy screen is very important. Okay, correct. And then you have to ask about the diet. In the diet, you have to ask that do you have any allergy to any or any indigestion to any wheat or bread or any bran like celiac disease. Okay, you have to take a history regarding did you notice any blood in your stool? Okay, Crohn's disease. Did you have any extra abdominal like intestinal symptoms like eye symptoms? Okay, any leg infection, any wound, any eye problem, any scleritis, episcleritis history? Because patient might have previous history but not present. They can present with a current issue of episcleritis or scleritis. So you have to ask these questions to rule out. Then chronic infection. Okay, sometimes patient with smoking may have TB or may have lung malignancy. Okay, so it's very important to rule out. Okay, and then your pheochromocytoma, as you said, but pheochromocytoma will present with episodic sweating. Okay, and it does not present with significant weight loss. Correct? Anyone has any question until now? Hello? Okay. So after that, the examination scheme should be very important. So once you start with the examination, okay, once you will start with the examination, we have to take general history. I mean, general examination. You have to ask the patient. Ma'am, did you ask about the BMI or did you notice the BMI?
No, sir, I didn't ask.
Because chronic weight loss, you have to pay attention towards the BMI. What is the
Okay.
general appearance of the patient? This patient has a BMI of regarding around 21. Okay, so you start with the hands. Okay, in the hands, you have to check for the tremor, sweating, okay, any nail changes, any skin changes, and then you have to check the pulse and then BP in the both the arms, pulse also in the both the arms. Once you done with the hand, you have to check the neck, you have to check the JVP, and then you have to check the eyes. In the eyes, you have to check for any scleritis, episcleritis, pallor, jaundice, and then you have to check the eye examination for diplopia. Very important. Sometimes, usually, the thyrotoxicosis, I have given you the specific findings like proptosis and lid retraction and everything. Usually, the patient does not present with this classical sign, but they may present with diplopia, and most common presentation of thyroid eye in thyrotoxicosis is complex ophthalmoplegia.
Oh, okay.
How you will ask the patient to do regarding this?
Head shape movements.
Yes. So painful movement in every direction, or sometimes more over toward the lateral directions. Patient may have complex ophthalmoplegia. Okay, very important to rule out. Okay, and diplopia. And then you can do for lid retraction, you can ask for proptosis and lid leg. You have to do. Okay, then thyroid examination is must. You have done very good. Okay, so thyroid examination, this is a examination you have to check the double permission, one with the examiner and one with the patient also. You have to ask the patient that, sir, I'm going to check your gland in your neck. Do you have any pain at the moment? Because thyrotoxicosis, sometimes it could be painful. Okay. So you have to ask the patient and take his permission whether he's able to undergo this test or examination or not. Okay.
Okay.
Then you go behind, you ask the patient to take the sip of water, you put your hands and then ask the patient to swallow. Okay. And after that, you feel the gland and then you have to check the whether the thyroid swelling, whether it is a both side or unilateral, whether it is a diffuse, tender or non-tender. Okay. You have to check the characteristic of the thyroid neck. correct?
Hmm.
And then you have to check the extension, retrosternal extension and thyroid bruit. Did you have checked that auscultate for thyroid bruit?
Yes, sir.
Okay, very good. And then you have to check for the murmur and an abdomen. You have to check for any organomegaly. And in the legs, you have to check for the thyroid acropathy, any leg edema, any ulcers, any pigmentations. Okay, and reflexes in thyrotoxicosis not that much warranted, but it is most important to rule out in hypothyroid. Correct?
Yes, sir.
All right. So once this should be your scheme of the examination because you have very limited time here and you have to be very systemic. In the history, you have to pay attention regarding the malignancy. You have to pay attention during regarding the chronic infection, which is very important to rule out. Examiner will mark, and if you will not elicit this history or this condition in your history, they will not give you full marks. Okay, correct. And regarding your DD, here your DD was little bit problematic, ma'am.
Okay, sir.
You said that your first diagnosis was
Thyrotoxicosis, Graves' disease.
what was your first diagnosis? Thyrotoxicosis and Graves' disease, and you said this is here the top differential diagnosis is your hyperthyroidism, malignancy. You have to rule out another other GIT causes as well. Malignancy, any malignancy, but specific GI malignancy, chronic infection could be your TB and HIV. You have to rule out. Very important. You have to ask a specific history regarding this. Okay, and pheochromocytoma in the list.
Okay, sir. I got confused because this
Top three.
the second and third DD for weight loss, sir, malignancy and chronic infection.
Chronic infection, yes, weight loss, because he was very worried about the weight loss, and that was the his main worry. Palpitation he had since last 2 months, but weight loss he has for 6 months.
Okay, sir. Got it.
Right? We have to also pay attention to rule out the history of diabetes. Diabetes could be one of the cause for weight loss with normal appetite. Okay, so you have to pay attention regarding the diabetes history as well. Okay, patient might have not been diagnosed or he might not been evaluated for this. So you have to ask a specific question regarding polyuria, polydipsia, any poor wound healing is there or not.
Okay, sir.
Okay.
I thought like weight loss with palpitation, I have to give DDs like that. I thought so, but
Yeah, so it could be according to your, because what else? What are the other DDs you can give here?
um,
For palpitation, what
uh,
else? What other DD you can give?
Anemia.
pheochromocytoma.
Anemia, but the patient does not have any
Mm.
pallor, does not have any signs and any history of anemia.
Yes, sir.
He was
I
alcohol history was not there.
not
Yes,
there. Anxiety, anemia. That's what I told, but
it was not there.
mm,
In the history, it was not there.
yes, sir.
Correct. So what else you can? So you have to be very sensible regarding the DD, because don't always assume that this could be the cause. If you will find a thyrotoxicosis, it's very easy piece of cake for this condition and this at this level in the cases. So you have to be very vigilant to rule out the cause, to look out for the complications and associations.
Yes, sir.
Okay, because if you will see here, let me just see, this is your mark sheet.
Mm.
Okay, so your these are the skills differential diagnosis. You will be assessed and you will be marked for that. So if your differential diagnosis will not be sensible, your clinical judgment and your investigation and your plan of management will also go in the other direction. Correct? And if this will not be in a correct align with the examiner, what have they have calibrated, your concerns will also go here and there. Okay, so it is also always a interlink marking. So please pay attention that what the patient is giving the history. Okay, outside you can outside the room where you have the 5 minutes, you can make the table of weight loss, you can make the table of palpitation. Okay, but you have to keep these things in align and you have to pick the point what the surrogate or what the patient is saying to you.
Okay, sir.
Correct. And regarding the imaging and regarding the investigation, your clinical judgment. So you only like told regarding the thyrotoxicosis, but you did not speak any differential diagnosis investigations. Correct?
For the differentials.
Yes.
Okay.
Suppose if the patient has any weight loss, unexplained weight loss, so you at least you can go for any if the patient gives you the history of any malabsorption syndrome, so you can go for any stool test or any
TTG
NTTG or
antibodies.
yeah, you have to rule out celiac disease. You have to work up for that. You have to go for ESR, CRP at least. Okay.
Yes, sir.
Correct. You have to go for if the patient is giving you the history of any polyuria or polydipsia, you can mention regarding the
Blood sugars,
HbA1c or
HbA1c.
fasting sugar. Okay. All right.
Yes, sir.
Correct. And regarding the management, your management was also good. All right. So, anyone has any concern regarding this?
Assalamu alaikum.
Yeah, Walaikum Salam ji.
Yes,
Yes, doctor.
regarding the if the patient have a weight loss with a good appetite, still I have to go to put malignancy at the second DDs or can give it late.
It can be like it could not be the DD for the like top three, but if the patient is young, what you have to see what else it could be. So if you see the table or if you have read the book, usually the weight loss with good appetite, you will see the hyperthyroidism, you will see the pheochromocytoma, you will see the diabetes can lead to, you will see the malabsorption syndromes or malabsorption
Yes.
conditions. Correct? So you have to at least rule out for that. And malabsorption condition, it could be your celiac disease, it could be your ulcerative colitis, it could be your another tropical diseases which can lead to chronic giardiasis can lead to this. Okay.
Yes. Okay.
Sometimes endocrine condition can lead to malabsorption. So you have to rule out what it could be and what the patient is giving you the history.
Okay.
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 And
Thank you.
so regarding the thyroid eye, Just wait a moment, please. Anyone else has any concern, please? So these are the lead leg. So this is the normal. If you see, if the patient is a lead leg, once you ask the patient to look up and then down, there is a complete normal version of the human. But if it is a thyrotoxicosis, the lead will be leg. Patient has, this is the lead leg. Okay, this is thyroid eye disease. Okay, and a patient might have esotropia, double vision. You can see here the esotropia of the left eye. Okay, and patient might have diplopia or complex ophthalmoplegia as well. Okay, this one is also leg of thymus and exposure keratitis. Sorry, exposure keratopathy. So usually patient, once you ask the patient to close the eyelid, there is no complete closing of the eye. Okay, this can happens in leg of thymus because of the chronic lid, upper eyelid retraction and stiffness. This is another condition of the. So this is your ptosis. This is your normal eye. This is your ptosis. Okay, at least up to 2 mm it should be there, and then upper eyelid retraction. So the eye, the sclera should be visible here, and this is lower eyelid retraction. Okay, all right. Can someone say this? What this condition could be?
Bilateral ptosis.
Ptosis,
Chemosis?
myasthenia, sir.
Which one? The upper or the down?
Bilateral
Okay,
ptosis.
so first we will discuss regarding these men. Can anyone say what this condition could be? You will see this patient in your practice as well and in the exam as well. This is myopic eyes. Okay, see the frontal balding. Okay, this is a case of myotonic dystrophy. Okay, patient also have drooping of the eyelids. This is. Can anyone say this one?
Left ptosis. Third of palsy or Horner syndrome.
Could be, but unilateral also it could be. Your concerns are like, I mean, your reasoning is okay, but it could be a
Myasthenia.
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 Okay, for your third nerve palsy and everything, you will ask the patient, you will see the pupil, you see the condition and the primary position of the eyeball. If you can see here, the primary position of the eyeball is normal. If it is a third nerve palsy, then
Will be down and out, sir.
correct. Okay, so it is also you have to take your clinical judgment before you speak in the exam, please. Because once you have given your answer, your explanation, it has been written by the examiner. Then no matter how much explanation you give. So please pay attention before you speak. Okay. All right. So anyone has any query, please?
So can you repeat this last point?
This one. So this is, if you see that the patient has a unilateral ptosis here. Okay. And unilateral ptosis, and you see the primary position of the pupil. Here also and here also, if you even see from the distance, the primary position of the pupil is in the center. It is not like somewhere down or out something. Okay. to say for the any cranial nerve pathology, first you have to ask the patient to uh, up the eyelid, and you have to see the primary position of the pupil and the eyes. Okay, correct? So here the primary position of the eye is center, not down and out or not in and up, which we can see in the cranial nerve palsy. Once you ask the patient to up the eyelid, then you will see the pupil also, whether it is a constricted pupil, dilated pupil, reactive to the light, non-reactive to the light. Correct? Suppose it is a reactive to light. If it is not reactive to light, then if the primary position of the eyeball is down and out, and your pupil is non-reactive to light.
Third nerve palsy, sir.
Yes, which one?
Surgical? Surgical.
Surgical. Correct. So it could be emergency. Okay. So that's how you go clinically. So we have to be very careful with the examination and the findings, because if you will see here, let me just show this mark sheet again. They have clearly written the criteria. So even if you are not sure, identifying the clinical signs. Okay. You see here, finding signs which are not present, directly unsatisfactory. So if you think, you might think that this could be, but if it is not there, and if you have said this, it means that you have made up sign. Even if you have presented 5 signs which are correctly there, and if you have said 1 sign which is not there, they will give you the unsatisfactory, because this is one of the criteria, that finding signs which are not present. Do not made up any signs. So if you're not confident, you are not sure about the findings, don't speak. Okay. All right. So anyone has any question regarding this, or any approach regarding weight loss or palpitation?
So to check for lid retraction, we'll be in the front of the patient and doing that inverted U-shape movements.
Yes.
And what we will be looking for, sir?
So lead restriction will be, your lead will be retract. Okay. And you will have I show you the, let me show you once again. I just showed you what you will see. Can you see?
Yes, sir.
Okay. So this is your lead retraction. So once the patient will see up and then normal, then the upper sclera will be visible. The eyelid will be up. Okay. So this is your lead retraction.
Okay, sir.
Even in the normal gaze, the patient will have this condition. Okay.
Normal gaze, okay, sir. And when we are asking to look up and
This is lead leg. Correct?
Oh, okay.
The lead will be lagging, where when the patient will see, it will take some time to come down. And why? Because of this. These all are the thyroid eye complications. Why we see? What could be the reason?
That
Yes,
glycans.
deposition of aminoglycans. That's why patient present with thyroid, in the thyrotoxicosis, the eye symptoms are more prominent.
Yeah, yes. And
All
one,
right.
like these two, we will be doing for then head-shaped movements, and we go to the side of the patient and see. Is that
If you
required?
go with the side, you will see this. From the side, you will see this one.
That step is necessary in
Okay.
exam, sir.
It just take 1 to 2 seconds, ma'am. Once you are
Oh,
just going behind, or once you are coming from thyroid examination, you can just look from the behind. From the behind, you can check the this eyelid and lid retraction, and the primary position of the eyeball is there, if it is positive or not. Okay. But more than this, never forget to check for complex ophthalmoplegia, which
okay.
is the most common presentation in thyrotoxicosis initially. If the patient who has untreated thyrotoxicosis or very severe thyrotoxicosis for long time, then they may present with this thyroid complete like Graves ophthalmopathy or lid leg or this kind of esotropia. But if it is initial stages like 3 4 months or just tremor palpitation, patient may not have this condition, but they definitely or most likely to have complex ophthalmoplegia.
Okay, sir.
Okay. All right.
And one more doubt, sir, like when we are examining the thyroid gland, first we give sip of water and observe from the front at the level of the thyroid, and then again when we are examining from the back, that time also we give water and ask to swallow, sir.
Sorry, can you please repeat once more?
First, on examination of the thyroid gland, we look from the front at the level, we bend down and look at the level of the thyroid gland and ask to swallow. And
Okay.
and again, when we go back to
Yeah. So from the front, if you will ask the swallow, what you will look for?
whether it is moving with swallowing.
Yes, and you ask the patient to protrude the tongue also,
Okay, sir.
if it is going up or not. And from the behind, you see whether it is moving with your, when you put the hand, you check whether it is moving with the swallowing or not.
At
From the
that time
front, you see
also.
the primary position, what is the, if it is any visible swelling or if it is any goiter is there, if it is a unilateral, bilateral, what kind of the uh, visible swelling, because sometimes patient may be covered. Okay, suppose your exam is in winter session or in a place where the cold is there, patient might be sitting with the neck is covered. Okay, so you have to ask them to expose and you have to see the primary condition. You have to ask them to protrude the tongue and to see whether it is comes with the tongue movement or not. And then you go from the back and then you check with the putting your hands over there.
Oh, okay, sir. At that time also we give water and check.
Yes.
Okay, okay.
All right. Anyone has any concern regarding this topic?